Well, ladies and gentlemen, thank you for having me here. And I think it's quite clear that one of the big issues in evaluating what to do is the interpretation of all the let's say, the science we have. And I will show you that also with respect to laparoscopic lavage, it's very difficult, even despite the fact that we have now a couple of randomized trials, to know what to do. And I would like to share with you some thoughts about that. These are my disclosures. They don't have any relationship with this study. I think in acute diverticulitis there are two big debates, and then first of all it's the use of antibiotics. We have addressed that, and also the use of lavage, laparoscopic lavage in the Hinchey 3 patients. And of course we're talking about Hinchey 3 and not Hinchey 4 patients who obviously have a fecal peritonitis and probably still an open connection between the bowel and the peritoneal cavity. Those patients are not suitable for lavage. They probably need resection. So what kind of options do we have? We have, for the Hinchey 3, we do have antibiotics and drainage if necessary. We didn't touch on that. I will show you one slide on that, just for the discussion later on. We have laparoscopic lavage and we have resectional surgery. And then if we think of resectional surgery, we have the Hartmann's procedure, which is traditionally done in an open manner. But we also have to consider that nowadays, with the increased use of the laparoscope, we can do that very easily laparoscopically, taking the specimen out through the future stoma site. And then we have resectional surgery with anastomosis with or without an ileostomy. Well, my topic is lavage or resectional surgery for Hinchey 3. And we addressed that in Europe in 3 big trials. The Scandiv trial coming from Tom Ursland in the group from Norway together with Sweden. And the Dilata trial was coming from Eva Hägglund from Gothenburg in Sweden. Also included a couple of Danish centers. And then we had in the Netherlands, we had the Ladies trial, which essentially consisted of 2 arms, one addressing the issue of the value of laparoscopic lavage and the other addressing the issue of doing a primary anastomosis or a Hartmann procedure. So I always show you the, let's say, the conclusions of the different trials. And the first publication was done by the Gothenburg group, the Dilata study, and they reported on the short-term results of their trial. And as you can see, they concluded that laparoscopic lavage as a treatment for perforated diverticulitis, Hinchey 3, was feasible and safe on the short term. The Lola trial, looking at lavage for Hinchey 3, had a 1-year endpoint. So it took us a little bit longer to come to a conclusion. And we concluded that laparoscopic lavage was not superior to a sigmoidectomy for the treatment of purulent perforated diverticulitis. We had a superiority trial looking at a combined endpoint of mortality and morbidity. Then the Scandiv group reported their results, and the short-term results, 90 days results, were relatively disappointing for lavage as well. So they concluded that these findings of the study did not support laparoscopic lavage as a treatment for perforated diverticulitis. Well, later on, the long-term results of the Dilata came up, which were similar to the first report. And then the Scandiv group reported their 1-year results. So they had let's say, an overall morbidity and mortality in both groups now, not only for 90 days, but then for a year. And as you can see, they relatively changed their opinion that the lavage was not discarded anymore, but one should weigh the advantages of laparoscopic lavage against the risk of secondary intervention, which is associated with the Hartmann procedure. So what did the international literature with it? And it's amazing that in 1 year time, we only had 3 randomized controlled trials, but in 1 year time, there were already 5 systematic reviews addressing this issue. And all of these systematic reviews had different conclusions. Safe and effective lavage. Lavage was superior, and then we had another systematic review concluding that lavage was ineffective. then safe and quick alternative, and then a conclusion, more reintervention and similar mortality. So what's going on? So we all apparently interpret the same data in a different way, and I think it's all about attitude. So what's your basic feeling about a certain procedure? What you're feeling about laparoscopic lavage? What about Hartmann's procedure? Probably in the US, maybe legalization is something which matters. So it's difficult to conclude. So let's go back to the different study groups. Well, this is the Gothenburg group. You can consider them as the Vikings, and they thought lavage is the best. No Hartmann's anymore. Then we had the Oslo group from Norway. They thought that lavage was associated with more interventions, and Hartmann is the best. You see, they didn't care about stomas. And then they even put on their website that, coming from this very nice and young investigator, new is not always best in surgery. And then you can understand that the older guy said the old method is still the best, of course. So that was their conclusion. And so we're back to the times of Henry Albert Hartmann's doing Hartmann's procedures. Well, we already had the ASCRS guideline from 2014, and there they also considered the lavage in generally not appropriate, the appropriate treatment for the Hinge 3 diverticulitis. So what about the Netherlands? Well, we had to make up our minds. We did not really know what would be best, and so we really looked, discussed a lot how we should phrase our final conclusion. So this is more or less a summary. The LALA very positive, Scandinavia negative, and we did not know. So if you take all these trials together, what have we learned from these trials? So if you look at the 1-year overall mortality rate, you see that there was no difference between resectional surgery or lavage for Hinge 3. There was a difference with respect to the stoma-free and alive at 1 year time. So the lavage group had a lower rate of stomas. And if you looked at never had a stoma, that you could also see that in 4 out of 5 patients who had lavage, they never had a stoma, which was quite clear that it was different for the resectional surgery. We have to realize that at 1 year time, if you take the accumulated morbidities and mortalities of all the procedures, for the 3 trials, it was more or less the same. So this means that the drawback, the short-term drawback of the lavage, the failures are largely compensated by the complications caused by, let's say, further surgeries after Hartmann's procedures. And we also have to realize that taking all these complications together, that patients who did not have their Hartmann's closed, they do not add to the mortality and morbidity rates in the overall figures. Well, what about costs? Lavage is cheaper. We've seen it in 2 studies. So this is the trade-off. So lavage is associated with more early reinterventions. 3 out of 4 patients never had a stoma, maybe even 4 out of 5. There's a lower 1-year stoma rate. Resectional surgery is associated with less early reinterventions, be it surgical interventions or percutaneous interventions. There's more late surgery and there's more costs. So we have to look into the reason why lavage didn't work in let's say 1 out of 4, 1 out of 5 patients. So we looked into our data, and we have seen that on the short term, the misdiagnosis of Hinge 4 being treated as a Hinge 3 was an important cause of a failure of the lavage. And we also had perforated cancers that were included in the study, thinking that this was a perforated diverticulitis. Of course, you cannot treat a perforated cancer with a lavage. And on the long term, the failures of the lavage were caused by the ongoing complaints of the patients, so they needed resectional surgery in the end. And we had a number of patients who turned out to have cancer, because all patients that had lavage needed a colonoscopy afterwards to rule out this differential diagnosis. So what we learned from this is that we really need to optimize the to identify the patients who have a perforated colorectal cancer and Hinchy 4. So, to wrap it up, I think true Hinchy 3 patients can be lavaged with a higher rate of success. So if you take out all the Hinchy 4s that were lavaged and the perforated cancers out of the studies, you can see that the success rate is up to 90%. And we have to exclude, during a laparoscopy, the Hinchy 4 and the perforated cancer. Well, preoperatively, you might do that by giving the patient rectal contrast during the CT scan. It's very rare that in the emergency setting, radiologists give the patient rectal contrast. And you want to see whether there's still a connection between the bowel and the abdominal cavity, indicating that this is truly a Hinchy 4 and not a Hinchy 3. And you want to see whether there's a cancer or not. And we know that in complicated diverticulitis, up to 10% of these patients, they have an underlying cancer. So what can you do during surgery? Maybe we should explore the phlegmon a little bit more, particularly when it's sitting in the orifice of the pelvis, so we cannot see the Douglas pouch, whether there is stool, and we only see the purulent peritonitis on top of that. And we could do a sigmoidoscopy during surgery in order to rule out the Hinchy 4 by a bubble test or to see whether there is cancer. So after making up our minds, I think nowadays, let's say the LOLA group considers lavage a good option for the true Hinchy 3 patients, but we have to exclude the Hinchy 4s and the perforated cancers. 2 slides on different applications. There are 2 interesting studies, one coming from Finland and one coming from Paris, treating patients who have localized perforated diverticulitis with antibiotics and percutaneous drainage if possible, if necessary. And they did very well, high success rates. And one, let's say, add-on for the previous speaker, these are the results of the DIVA study, so the second arm of the ladies' trial, showing indeed that if you compare primary resection versus Hartmann procedure, that particularly the patients with the primary resection have a lower stoma rate at the end of follow-up. So these are in line with the previous data, and this, I think, is up to date. It's the study with the largest number of patients included. So, to conclude, does laparoscopic lavage have a role in the current management of diverticulitis? It's a big yes for the true Hinchy 3 patients. I thank you for your attention.